Hello, and welcome to Workforce Wisdom. I'm your host, Christy Bray, Chief Strategy Officer at PracticeLink. This podcast focuses on the latest trends in healthcare recruitment while showcasing innovative strategies, success stories, and fresh perspectives affecting the healthcare workforce. These episodes will lead to in-depth, thoughtful discussions with recognized industry-leading healthcare professionals, exploring the challenges of healthcare recruitment and beyond. Whether you're an experienced recruitment professional or just starting out, this podcast aims to help you discover how experts are reshaping the industry, leveraging technology, and fostering inclusive hiring practices. Today's episode of Workforce Wisdom: Transforming Healthcare Recruitment Through Strategic Recruitment Planning and Innovation. I'd like to welcome my guest, Ron Flower. Hi, Ron.
Hey, Christy. Thanks for having me.
Yeah, it's good to see you again. For our listeners, Ron is a recognized expert in provider development planning, medical staff development planning, and community needs assessment. For more than 23 years, Ron has worked directly with 3D Health's partners to develop customized solutions that fit them and the markets they serve. Having started with 3D Health as an analyst, he knows every component of 3D Health's provider development planning from the ground up. His experience spans 45 states and includes academic medical centers, critical access hospitals, both national and regional health systems, physician groups, urban and rural markets, and everything in between. Ron is also a noted speaker, regularly presenting at annual conferences, guiding educational webinars, leading roundtables, conducting interviews and podcast discussions, and leading board meetings, retreats, and executive leadership meetings for hospitals and health systems nationwide. Prior to 3D Health, Ron was the director for SCORE Educational Centers, a subsidiary of Kaplan and the Washington Post Company. When not at work, Ron usually spends time with his wife Danielle and son Sebastian. Together, the three enjoy traveling, riding bikes, playing soccer, spending time at the beach, rooting for the Chicago Cubs, and anything else that involves friends and family. Welcome again, Ron.
Thank you, Christy. Happy to be here.
So, Ron, your work at 3D Health focuses on developing strategic recruitment plans for hospitals, health systems, and physician groups. Can you share how your career led you to this space?
Absolutely, Christy. So I took a little bit of a different route getting to healthcare than some. I graduated from Indiana University back in 2000 with a degree in elementary education. So at one point, I wanted a career in molding young minds. I worked in the education sector for about 5 years. Actually moved up to Chicago to work in the education sector for a tutoring company. And about 5 years in, I met Shane Foreman. He was about 2 or 3 years into developing 3D Health. Had a couple conversations with Shane, and I was hooked. He kind of hooked me with the analytics, the data, also business and strategy. Didn't know much, if anything, about healthcare at that time. Had spent very little time in the healthcare industry, but was excited to learn new things. And so Shane brought me on as an analyst. Started with a lot of our primary research that our team does today. And over the past 20 years, I just kind of kept working my way up, learning more about the industry, how it works, the strategies that we build. And so here I am today, president and CEO of 3D Health.
You know, what really led, Shane and you and the founding of 3D, what problems, I guess, is a better question, what problems in healthcare are you guys looking to solve?
So Shane actually founded 3D Health. The founding of 3D Health was really born out of Shane's frustration and hope that there's a way to do things better. So Shane came from big box consulting. And while I've never worked in big box consulting, what I've understood about it is, from Shane's perspective, it wasn't providing, for the price that clients and hospitals and health systems were paying, it wasn't providing innovative solutions. It wasn't for the workers or for the employees of big box consulting. They were undervalued, overworked. And so Shane took a step back and said, the only people really benefiting from this type of a consulting practice were the partners at the top. And so when we started to develop 3D Health, and I came on early on, we said it's pretty simple. We want to give clients what they want, but most importantly, by working with the clients. And so, in the beginning, we had a bunch of different service lines that we did. We actually did market assessments. We did pro formas, financial feasibility studies. We assisted with joint ventures between physicians and hospitals. But it was pretty early on in the first couple of years of me working with 3D that we identified a real opportunity and a real need in the physician strategy or the development of recruitment plans for hospitals and health systems. I think back then, most of what was being done was still very compliance oriented, very kind of market surplus and deficit, very high level, very driven by the HR department instead of the strategy teams. And so we said, I think there's a big opportunity here to help hospitals and health systems get in front of all of that. And that's what we're trying to do with 3D.
Yeah, I know in our work together, we've always agreed that the recruitment team are those responsible, to go out and fill the jobs. Yeah, they play a key component when you're looking through your workforce planning and all of that. How does how should the strategic recruitment plan impact the work those recruiters are asked to do? And then potentially, some of the operational leaders from a workforce management issue.
Yeah, so from our perspective, it sets the tone for everything, right? So as you pointed out, the recruitment team, the operational team, they need a plan to follow, to know where we're going. And all too often, the recruitment is too reactionary. We have a vacancy that's opened up, a gap that's opened up. We need to fill that. And so where we feel like this fits in is in the front end planning, thinking about over a 3-year, 5-year, 10-year horizon. Let's get ahead of that. Let's be less reactive, more proactive. And so this sets the tone. This sets the direction for that recruitment team to say, what will I need to start recruiting today? Of course, there's always going to be emergencies and fire drills. But also, it takes me longer in a rural market to recruit a urologist than it does in other markets. Heck, it takes a long time to recruit urology
Or forever.
But if your recruitment team can get ahead of that by a year, 2 years, 3 years, sometimes 5 years, and start planning for that well in advance, that sets them up for success in what they're doing.
Sure. One of the things, this isn't one of our planned questions, but I'm curious about where historically you would look at the age of your provider staff or your physician staff and really just kind of put pins in those on when you thought they might leave, right? To kind of make a rough outline of a plan. Is that still what people do, in their process planning?
Yes and no. So when I started doing this 20 years ago, to your point, it would be, let's look at our providers, and how we define our providers could vary quite a bit. Is that our employed network? Is that our independent friends? Let's look at that list of those folks and use a retirement age assumption or go down through the list and kind of think about who we'll need. It has a much finer point on it nowadays. So rather than here are the 50 providers that are going to be 65 or older, 67 or older, whatever it may be, over the coming 3 to 4 to 5 years, it's still that question, but then it's going through it with another finer lens and saying, do we need to replace all of these? Is sometimes there addition by subtraction? Is this a specialty that we need to replace just because that one physician is going to be retiring? Or is this an important part of our strategy moving forward? Do we want to replace in this specialty or this service line? And then more and more since 2020, we're finding individuals that are focusing on folks that aren't going to be 65, right? So those that may hit age 62 or 63 and say, I've had a pretty successful run at it. Healthcare is becoming more and more challenging to practice within. Maybe I want to wind down. Maybe I want to sunset. Maybe I want to retire at 63 rather than 65. So it's still very much kind of looking at our at-risk list, but then taking a finer point and saying, who do we need to put into our recruitment plans over that horizon.
When you look back at the care being provided and that being, does the health system want to keep doing that? Does the practice want to keep doing that? Is there still that community need there? And then equally, where can you backfill with other service providers? So is it an advanced practitioner or someone else, licensed clinical social work? I mean, you could get to a pretty big gamut of who that healthcare provider could be in the future or might have to be because we have a workforce shortage. But I know that's a common piece that you guys are looking at, kind of that whole support structure of healthcare for the community.
Right. How do you solve for those gaps? And conversely to what you were saying, if you have a 65-year-old who has had their practice for 30 or 40 years, they may be working at 1.5x, sometimes upwards of 2x, what maybe some of our young graduates coming out of medical school today want to work at. Also, more and more, it's not a one-to-one fill. More and more we're seeing, or our clients are seeing, physicians and APPs that want to work at a 0.8, a 0.5. So there are also a lot of thought lately in we have space for 45 primary care providers. But how many FTEs is that? And then also to your point, Christy, around advanced practice providers, I think more and more we're seeing heavier utilization of APPs across the country. But I think the focus lately has been on utilizing them more top of license, right? So what should an APP in an orthopedic surgery practice be doing? How should they be seeing patients as an extender or seeing patients on their own with their own patient panels, and trying to maximize that opportunity?
Yeah. Yeah, I do think just with the overall workforce shortage, that maximum top of license performance should be on everyone's radar from, any staff you have at the hospital, CNAs and medical assistants in a practice, and then upwards, so that we're just really getting, and I think, honestly, it's a great retention metric where they feel fulfilled because that's what they went to school for, that's what they wanted to do, in their life. So, we talked about a couple of challenges already, but, in your experience, do you have like a top three biggest challenges when really aligning recruitment planning, which, as you said, has historically been reactionary, with the community needs and maybe even market growth? I'm going to throw that in there, of the existing providers.
I have a top 10,
Oh,
but I'll
good.
start
Okay,
with
more
one
than
or
three.
two.
That's
I
fine.
think one of the biggest that we're working with a lot of clients on, and a lot of hospitals, health systems, medical groups, physician groups are looking at heavier than ever today is patient access. So we know there's a shortage in a lot of specialties across the country. And so therefore it's going to drive shortages or pent up demand to get into physician practices. But the healthcare industry, being as competitive as it is today, everyone's looking at how do I differentiate? How do I give patients the easy button at getting into my practices, whether that's giving them the information that they're looking for. I think one of the biggest things that is become in the crosshairs of our strategies is actually medical subspecialties. So often overlooked, often thought of as expensive, not producing a lot of procedures and downstream revenue, right? When you're thinking about finances and budgets. I think people have more and more been focusing on primary care networks to feed this proceduralists and the specialists, right? But there's that middle ground for the medical subspecialties, and several of our clients are finding tremendous success at investing in psychiatry, nephrology, rheumatology, cardiology, endocrinology, some of those specialties that may not generate a lot of revenue, but what they're doing is they're allowing for better patient access into the primary care network. So in rural markets or even suburban markets, a lot of primary care providers very much act as a primary care provider and a diabetic specialist and a psychiatrist. And that's causing them to not be able to have as large a patient panels. And so if we can fix some of the medical subspecialty needs and give our primary care the opportunity to refer to those specialists when needed, it allows them to have bigger patient panels, refer more downstream to the proceduralist. So it's a win-win from a physician happiness perspective, doing their work top of license, seeing the patients that they want to see, and from a budgetary perspective as well.
Yeah. Yeah, I know in my experience, we've had practices where the cardiologist was often acting also as the endocrinologist, which equally, like, that's not where they should be spending their time. Yes, they want to help their patients, but managing, their type 2 diabetes, it, is that a case where you would say maybe you should look at some tele-endo or some other, potentially an APP support that is that that diabetic counselor?
Yeah, absolutely. That's one of the biggest changes we're seeing as well is just virtual care across the country, especially amongst larger health systems and hospitals that have the capital to invest in that. But what do we need in way of neurologic care, psychiatric care, endocrinology care, some of those more cognitive specialties? What do we need boots on the ground versus what could be done virtually? And then how do we solve for that virtually? If we're a health system, do we develop our own program? If we're a smaller critical access hospital or community hospital, how do we work with some of the larger organizations or health systems to try to solve for that? So absolutely, the virtual care it has a space. And I think we're all figuring out right now, how does that fit into the space?
Hmm. Yeah, I think that will become very, clear very quickly is where patients want to receive the care and then a function of not having workforce to fill it. So how do you balance that? I think the virtual care becomes a big component for us in the future. Yeah, to solve those care gaps. Yeah.
Yeah, Christy, it's interesting because at 3D Health, we do a lot of consumer surveys. So we, like everyone else, we have gut feelings. We feel things that are this way or that way. More people may want virtual care or not. But rather than using our gut, we like the data, right? And so we've been asking lots of consumers across the country lots of different questions about lots of different healthcare topics. And our most recent study, and we're going to publish this soon, some findings from this, was all around primary care. And one of the questions we asked patients were, where would you prefer to see your primary care provider? In the office, virtually, a couple others that we had, over the phone, and in a big box store, in a CVS or in a Target. And 80% of the respondents said, I'd like to see them in the office. I want to go into the office for my well visits, for my checkups. That doesn't mean there's not an opportunity for virtual visits. I think they fit in a large way. I think it's just listening to the patients and understanding what they're looking for. On top of that, the other big finding out of that was that when you get into the 65 and older cohorts, the desire for virtual care starts to go up tremendously. See, that was a surprise for us. We thought older folks, senior citizens, they want to do what they've been doing for many, many years. They don't want to use the technology, but it's not the case at all. They would rather stay in their homes or stay in their place of comfort and see their physicians only when they need to, and do that virtually. So that was 60% of those age 65 or older said a virtual visit would be preferred to an in-person visit.
Did you know PracticeLink is not only home of the most widely used online physician job board, but we also have our own magazine? PracticeLink magazine has not only won several awards, including 2 ASBE Awards of Excellence in 2023, but it's also completely free. Over 375,000 physicians and residents receive copies of PracticeLink magazine each year, and you can too by visiting practicelink.com/magazine. That's practicelink.com/magazine. Thank you for listening. Now we'll return to the podcast.
So you've talked a little bit about that emphasis on that data-driven decision making, not just your gut telling you what's out there in the market, but how can healthcare organizations use the data analytics? Maybe they have some of this in-house. Maybe they're working with 3D or another consultant, but to really improve their staffing models.
I think it's multi-pronged. It's using the data, as we pointed out, but it's not using one piece of data. So all too often when folks are doing this internally, they have access to a couple different data sets. And I think data is helpful, but it's also can be dangerous as well. And so my recommendation would be to, if somebody's doing it internally or working with a third party, is to try to think about things from multiple angles before you're making the decision on what to recruit, what to hire, so that you're not duplicating efforts, right? So let's take the patient access as we were talking about. We at 3D Health make secret shopper phone calls to doctors' offices, right? If you're doing this internally, that's hard to do. There's lots of phone calls to make. I think in along the same lines, you want to pull data from your scheduling systems. So look at both. And if you can do this internally, do even a sampling of those. Compare the two. See where we have operational efficiencies to improve, right? So a lot of times when I bring the patient access wait times to a client, and they're not surprised by, let's say, half of them, but there's always one or two or three or four that are surprising. They take them aback. Well, who's closed in this practice? Or why are the wait times that long when our providers are working at the 40th percentile? So I think it's, if we just sometimes look at the wait times, or even if we just look at a broader market surplus deficit, the data can be a little bit misleading. So to look at the data elements across several different factors as they're making those decisions.
Yeah. Yeah, I know in the work that we did together, the secret shopper calls that's probably my favorite component, because it really does give you that picture of the pain points of entry into the health system or the practice, appreciate the work you guys do on that. What, as you look forward to the future, what role does the predictive analytics play in helping organizations really anticipate and not making those reactive decisions when they're addressing the workforce shortage?
Yeah, we're already incorporating a lot of that when we do our demand modeling. And so I think what you can do is you can look at a market supply and demand, as many do, and you can see where there are deficits across the broader markets, or conversely, where there's surpluses. And that can be misleading if we don't think and utilize the predictive analytics. And what I mean by that is, where's the market going to be in 3 years, 5 years, 10 years? Of course, you can factor in growth and aging of the population. You can look at the age of the physicians across the market. So that's one thing you can do. I think the other important factor is to layer in your strategy and help figure out how can we look at the current and the projected state in our market to drive how we accomplish that strategy. So what I mean by that is, I was working in a market recently where they said, our strategy is to build an orthopedic surgery center of excellence. Everybody wants a COE for orthopedics, right? They said, we're going to build this, and let's look at all of the data in the market. And I think several folks came in with very open minds about this discussion. And one of the first things we looked at was market surplus deficit. There was a surplus of orthopedic surgeons in the market, right? So we didn't stop there. They were a little surprised that there was this surplus of them, but then we called the orthopedic surgeons and we found out that the wait times were a little bit longer than the national averages, right? So that's showing you that there's a little bit of a need. Those are two conflicting data points. Long wait times, access issues getting into orthopedic surgery, but then plenty of orthopedic surgeons, it appears, in the market. We took those two data points and we looked at their supply then of orthopedic surgeons in the market, their patient population. And really quickly what we found out is, while there were enough orthopods in the market, they didn't have enough orthopods specific to their organization and their patients. So we're using the predictive analytics to see if we modeled, we're able to increase the referral flow from our primary care network into those orthopedic surgeons. How many more could we fill? How many more could we bring in to start up this program? The output of all of that, they started a center of excellence, but rather than going and finding 15 new orthopods to bring to market, which was the original idea, they decided, let's partner. Let's figure out who's already in the market that's in some way aligned with us, and let's see if we can bring them under the fold of our center of excellence while we also bring some new providers in. And it is incredibly successful right now.
Yeah, that is a great, a great example of really looking at where you feel like you need more, but it was there. It may just not be under their roof at their
Yeah.
time and at that time. And then how do you partner? I know before it became really the trend to buy and acquire private practices. Where I worked in organizations that did much of that same work, and it just created just such a better synergy within the whole healthcare community, like in town, because the folks knew that they worked together to create that. This was still an independent ortho practice or an independent surgery practice, but they both helped create centers of excellence within their own domains, and that just made a huge difference in the reputation of the health system.
That's one of the areas, Christy, where when we started this 20 plus years ago, we realized, and it still happens to a large degree amongst a lot of organizations, where recruitment planning is very siloed. It's very departmentalized. And in today's day and age, they all have to work together. It helps with physician satisfaction, as we're just pointing out. It also helps you understand the whole picture. So another example is we were working with a client that wanted to develop their oncology center of excellence. They had 5 hematology oncology physicians who weren't very busy, yet the oncology department said, we want to go out and recruit more oncologists because we need more oncology business. So when you look at it in the whole picture, we were able to quickly realize, or they were able to quickly realize, they didn't have the primary care network. They didn't have the patient network to funnel the patients when they had cancer or cancer-related treatment was needed to their oncologic program. So the solution to getting more oncology business and filling up our current provider base, which was unhappy because they weren't busy, they weren't doing what they wanted to do, and was to build out their primary care network by a better aligning with and acquiring primary care within the market.
Mm-hmm. How often is it something that you uncover that, maybe there's a personality issue? Maybe they've never even met from a physician liaison perspective. Maybe they've never been introduced to some of the primary care referral source, but maybe they don't like each other. Like, how often is it something where it's a little less, it becomes a very delicate conversation where Dr. Smith doesn't want to send to Dr. Jones because of, something in the past, or maybe a quality of care issue that you uncover in some of your assessments?
Less often than it used to be, but it still happens from time to time. That's why 2 of the other elements that I would encourage anyone to think about in developing a workforce plan would be interviews and a survey, right? So getting the insights and perspectives of both your senior physician administrative leaders and also your boots on the ground clinicians. I have done these plans before where the market says we don't need more of this, and then 90% of the medical staff says we need more of that. There's a disconnect there, right? And then the interviews can bridge the gap, and you can figure that out. Just this week, I was on site I was at a client site, and in the survey, that was one of the things that came up around a particular specialty was clinical and service quality issues. It was a surprise to the leadership group that I was working with. They hadn't uncovered that yet. They hadn't discovered that on their own. And so they were able to, they're about to embark upon kind of a discovery session and say, okay, we thought we had this service line set. These providers aren't very busy, and now we're starting to uncover why they're not that busy. It's not that we don't have the patients, it's because our primary care base doesn't want to send their patients to our own providers. They want to send them across the street to our competition.
Yeah. Yeah. And I hope that that's becoming less, especially the quality of care, like less of an issue. But, some of these things, they do get political over time. If practices were competing at one time, or, there's just, there was something, or there was a bad patient outcome, and it can become hard for folks to forget. When would you tell health systems that they should do those interviews with their medical staff? Should they outsource it to someone? A survey, could be pretty simple, SurveyMonkey or, some other tool, right? But those interviews and the one-to-one conversations, how do you suggest folks do that?
Yeah, I think I'm biased. I think that you should outsource this. No, in all honesty, I think I used to worry a lot about confidentiality, right? So I'd sit down with a physician or an administrative leader, and one of the first things we would say, and we still do, is, listen, this is all confidential. We're going to report back in aggregate. What we've quickly found in doing hundreds and hundreds, if not thousands of these interviews, especially physicians, they're super excited and more than welcoming to give you information if they feel like it's going to be heard, right? So if it's not going to just be lip service, they feel like this is going to do some good in helping the organization, helping their patients, they're not worried about giving that information to the appropriate person. So I say all that, meaning a third party helps because you have that go-between, but I think if you have the right messaging and you frame it in the right way, and then it's not lip service, and you show them how you're utilizing the information that they took their precious time to provide to you,
Right.
you'll get just as good information if you did that internally.
So what other technology pieces would either a health system need or do you guys use to really assess the patient demand and ensure those appropriate staffing levels?
Yeah, so from a technology perspective, really two big things come to mind. It's the supply and the demand. So supply is one of the most difficult things to pin down in any market, no matter how well versed you know your market, or if you have an outside firm come in and look at it. I think you have to use the technology carefully. And what I mean by that is there's a lot of organizations right now, there's a lot of third parties that are attempting to use claims databases and attempting to use NPI databases and state license databases to develop a supply. I think it could be a good starting point. Our research has shown that they're typically about 70 to 75% accurate, right? And so if you're building a plan that is going to help you identify how to spend millions of dollars, I don't think 75% accurate is good enough. So what I would say to that end is, unless you want to have folks do primary research, do online research on the web and manually entering things, there's coders that can write code to scrape websites of information. 3D Health is doing some of that. We also utilize AI in helping merge databases, bring in NPIs and understand if a provider is, across multiple specialties. That said, technology can only take you so far. You still have to pick up the phone and make phone calls and do primary research to get that supply. And then on the demand side of the equation, that's where we utilize it most heavily, is just understanding with pinpoint accuracy, what is the demand for a population by age and gender in a market? When do you need to adjust for incidence rates, right? For geography, for ethnicities, for payer mixes within a given market. And so being able to have a demand model that's not necessarily ratio driven, but more of a use rate, the ability to play around with a lot of different scenarios and say, let's tailor this demand to my people, my market. Are we in the mountains where orthopedic surgery is more needed due to the outdoor lifestyle? Are we in areas where we have higher diabetes or obesity, right? So having a technology-driven demand model to adjust and adapt that demand specific to not only your market, but then to take that one step further and say, who are my patients within this market and what do my patients need, right? So the multi-layers there on the demand side.
Yeah. Yeah, it sounds like no shortage of opportunity for analysts out there who can get in and dig through some of these weeds or understand the technology and what you're trying to use there.
Exactly.
Yeah, yeah. Let's talk a little bit about provider productivity because I have worked places where it's very quick of the physician group leaders or even the CEO of the hospital to say they're not busy. just fire them and get somebody new. Okay,
Right.
that is an impossible task to ask your recruitment team. Let's just get rid of them. They're at the 40th percentile. We can get somebody else. Okay, first of all, you can't. And second of all, they may come in and produce at the 35th percentile. So I would have rather had that 40th there, and obviously a gap of care. So let's talk a little bit about, that struggle between provider productivity and efficiency and equally workforce retention, right? Because, if they're busier, then, let's keep them happy. Or maybe they want to be that 0.6, that 0.8. But what strategies have you seen work best to optimize those workflows? And it may be that blended environment where you've got some 0.6s. How many 0.6s do you need to fill up and make sure those patients are covered? Tell us a little bit about those strategies.
Yeah, I keep coming back to the data. Data, and here it's also conversations with the providers. So in our work as a piece of workforce planning, we look at what we used to call excess capacity. So I used to call this an excess capacity analysis, and we would frame it as if all of your providers were working at the MGMA median or whatever benchmark capacity we want to use, here's what you could be doing. We've pulled back from that because in more conversations with providers, physicians, practice managers, operational leaders, medical groups, we've realized that all things aren't created equal. Sometimes those providers want to be more efficient, want to be more productive, but they may not have the support staffing to help with throughput. Sometimes we find that they want to be more, but they're not getting the referrals from their colleagues, right? So do you have the primary care network to feed and refer to your specialist network and vice versa? Also, going back to the medical subspecialties. So this has been a big point of conversation around productivity amongst primary care providers, especially. In a lot of our markets, we find that when primary care providers aren't seeing the number of visits that they should be seeing or that we want them to be seeing, it's because the patients that they're seeing have a higher acuity of care, right? So going back to they're spending an hour with each patient as opposed to 15 or 30 minutes with each patient because they're doing more than what a primary care physician or provider should be doing in that, right? And then to your point, Christy, sometimes we bring someone on as a 1.0, we've contracted with them to work as a 1.0, and in the first year or two, they realize they don't want to be a 1.0, right? So they would rather have Friday afternoons off and Monday mornings off. And so going back to just having conversations when providers aren't working at a contracted clinical level. And then lastly, going back to the data, medical groups that are very successful and their providers working at the benchmark capacity that they have, they're measuring this on a daily basis.
Yeah. That was a note I wrote down was, I think it is more common that it's an operational inefficiency. You didn't mention in all of that, like, do they struggle with the EMR? Do they have the equipment, the supplies they need? And in that, do they have the human resource? They need one MA, two MAs, a scribe. Do they have those types of support mechanisms that's driving down their productivity in those cases?
Right. Yeah. Recently, we worked with a medical group that, interestingly, they were surprised when they saw the productivity levels. And so that was step one. You shouldn't be surprised. You should be monitoring that. But they were surprised. They felt like all of their providers were working at a high level. And when they talked to them, they all seemed busy. When they dug into it, it was the support staffing. And so when we built into the plan and we said, you want to grow, and how much do you have the opportunity to grow from within? They had the opportunity to increase the productivity of their primary care base by 35%. That's a big gap. But they said over the next 3 years, we're going to try to bite off 10% of that. We can't do 35% because that means we need more MAs, scribes. We need more front office people to take these calls and get these slots filled. So it was using the data to figure out what's the problem and then how do we solve for that and what's the cadence and timing.
Yeah. And in that example, they probably need more exam rooms.
Correct.
Right. I mean, so, building out shelved space in the hospital or a medical office building does not happen overnight. I mean, I've seen clinics try and cram some stuff in closets, but it doesn't create a great patient experience. So as we've talked about, the operational efficiency and really, opening people up to practice top of license, how can healthcare leaders really balance that operational efficiency with provider well-being and then prevent the burnout? I think one of the things you said is have those conversations when they might want to slow down, or they maybe their early career, but they're realizing it's a lot. Really, how do you help them balance that?
It's a critical topic today, isn't it? Is
Hmm.
balancing those two things. And I think oftentimes it's thought of as one or the other, and when it doesn't have to be one or the other. For us, it is strategic planning. It is building, designing systems that allow for both. Part of that is understanding sometimes where you have duplication of services, where you're bringing providers in that's duplicating what others are trying to do. It's being too reactive. When we lose somebody, it puts a lot of pain and stress and pressure on those that are left behind. We talked about capacity. Sometimes it's the opposite, Christy. Sometimes they're working at the 90th percentile, and we didn't plan ahead for that departure, that gap, what we would need when we hired 10 more primary care, how many more GIs we would need. And so that pain point in being able to recruit with the lead time that you need, right? And not being able to get ahead of that, that creates folks that are working at too high of a capacity of a level, which is good operationally, but not good for burnout. And then sometimes by the time you can solve for that, you've lost the two or three that were cranking away operationally, and now you have a service line or department that's broken.
Right. We've talked about virtual care, telecare. What we haven't talked about is supplementing your workforce with temporary staff, like locum tenens, physicians, or other folks to maybe reduce some of that burnout, give you some ramp room to recruit,
Yep.
but also give them a little bit of a break. Is that common? Is that something that you get asked about, or how to incorporate those folks within the model?
It is. It is. And again, it all comes back to if you take a step back, if you look at the broader picture, you can get ahead of needing that locum. So a lot of locums usage is reactive, right? This doctor left unexpectedly. This doctor retired a year earlier than we thought they were, or heck, they are 66. We thought they were 56. We weren't really looking at them that closely. So a lot of it's being reactive, programmatically. Also, thinking carefully about what service lines are your priorities. What service lines do you want to provide the services for? Is it cost effective? I think gone are the days of, for most, let's be all things to all people, right? And I get it. Critical access hospitals serve a very, very different role in a lot of ways. But even critical access hospitals and suburban hospitals, what are the service lines that you want to prioritize? What do you need? And then getting ahead of that to reduce your locums usage, or saying, there's still going to be those times where I need 2 general surgeons over the next 5 years. I'll start recruiting for them now. If they come early, great. But sometimes the recruitment pipeline is left open, as you know, for 5, 6, 7 years. And so being able to get ahead and knowing I'm going to need a locum to fill this at this time if we don't have a candidate ready to start.
Yeah. And I thought of one other thing we've talked about in the past, that instance where you look at and you need 3.2 or maybe 2.5 FTE. And I would tell practice leaders and recruiters, like, those are attractive jobs. Those 0.5 jobs are pretty attractive to folks, even coming out of residency. Like, folks are looking for, they don't want the 2.5 FTE all to themselves, or they don't. And so I think adjusting for that, where if you can make the math work, the bodies might be 5 that equal your 3 FTEs. And so figure that out within, what you need from a workforce standpoint. Or maybe your 0.5 is a supplement of a locums that's, number one, taking call days off of folks who are really tired. You see that a lot in OB. I think you see it in some other specialties. OB is the one that comes top of mind for me. Just the volume of call that those folks are doing.
Yeah, absolutely. Because when we're doing these plans, one of the things that we see from time to time is we have the patience to support 3 general surgeons. We want or need, in order to keep them and keep them happy and efficient, we need 1 in 4 call rotation. We don't need a 4th surgeon
Right.
because that's going to spread everybody too thin, and that's going to work against our physician well-being as well. Do we try to build up our primary care base, our patient base, to be able to support that 4th surgeon? Or, as we're working towards that, do we work with a locums company to support that until we have the patient base to support 4 full-time surgeons?
Yeah. Yeah, that's a great example. Just alternative staffing is what I try and think about a lot from a solutions standpoint. Okay, we're going to combine these questions. So, what trends? Get out your crystal ball. What trends do you see shaping the future of strategic recruitment planning and workforce optimization? And then equally, what advice would you give? Kind of blend it. To me, those go together, but if you want to break them out, that's okay.
Yeah. Several that we've talked about already are trends that we're seeing and still seeing come to fruition, right? So building up your primary care base. Asked me 10 years ago, and very few people were really worried about primary care, right? Give me the surgeons, give me the orthopods, give me the cardiologists. Continuing to build up that primary care base and building it up in a way that is aligning with your specialist programs. So essentially mitigating the risk. A lot of organizations we work with, they have 7 orthopods, but they have the primary care network to support 4 of them. And maybe those 7 orthopods are busy today because there's not enough orthopods in the market, or they're the premier group and patients are coming to them. That's changing. Networks are narrowing, of course, on the payer side, but on the provider side as well. And so saying, let's build up the primary care base so we can mitigate that risk, not have more orthopods than what our primary care can support, not relying on the outside influence. The other piece of that I'm already seeing happening now, but I think it's going to gain traction over the coming years, is medical subspecialties. I can't keep coming back to it's not always an attractive conversation to have, especially when I'm talking with hospital and medical group CFOs. But the organizations we've worked with that have found ways to fill the holes in those key medical subspecialties, that allows that primary care base to be more productive and allows more downstream revenue. And I don't want to make this all about finances, but as the saying goes, no money, no mission, right? We have to keep the doors open to our patients to be able to solve for what we're trying to do. Those two, and then patient access, just continuing to find ways in a way where we can help patients get in, navigate the system. I think you mentioned it earlier, we talked about it earlier, when someone calls our practice and the wait time to see that doctor, that APP, is a month, 2 months, 3 months out, how do we help them get in the system? How do we help them get worked up with an APP? How do we help them see a provider who may be new in our network that is still getting ramped up? How do we shuttle them from our urgent care facilities if they don't need urgent care? How do we help shuttle them to our primary care network and get them in the mix there as well?
Yeah. Yeah, I'm glad you mentioned payer network, because that didn't come up through the whole recording here. But is the how often are you looking at payer network and some of the narrow or the gaps within the markets when you're looking at their workforce planning?
Yeah, it really depends on hospitals and health systems and organizations that have their own payer plan. We're looking at it 100%, right? Network adequacy is the word that's used, the term that's used, and looked at heavily. Do we have within network, within our group, the appropriate care for our covered lives? And if we don't, who do we need to network or align with outside of our group to make sure that we have network adequacy. More and more, those with insurance plans are saying, I don't want to contract with those outside of our group. We want to keep it wholly within. And so what do we need to recruit to do that? The other biggie is we have hospitals and health systems that are taking our data and looking at how many served lives do we have in our primary care network? How do we need to better fill the gaps to have network adequacy? How can we take that to Anthem, United, some of the Cigna, some of the other big players, and say, look, let's negotiate. We have 75,000 lives in our primary care network. Here's the data. Let us show you. And also let us show you the data that says we have the medical and surgical support services to care for those. So let's talk capitated payments. Let's talk about a payer network for these 75,000 lives.
Yeah. Yeah, I feel like that segment could be a whole other training session itself, and I don't know that I want to. It's probably too early for me to talk about capitated payment models right now, but yeah, the payer network thing. Again, you got to have the money to support the mission. So I don't want people to think it's just about finance, but it ultimately is. I say that all the time. You got to keep the doors open. So that's what any business looks at. So. All right, I'm going to close this out here with kind of some closing thoughts from you. What would it be if you could change one thing about how healthcare organizations approach workforce planning today?
Can I have two?
Yeah, sure.
And they're related. I would encourage workforce planning, strategic recruitment planning, to fall under the strategic function. So still, all too often, this is an HR-driven process. It's done in silos. It is done reactive, based on gaps that arise that are don't give us near enough lead time. I'm a big fan of this is a strategic part of our broader strategic plan. We need to loop in finance, service line planning, succession planning. This should be, when we think about our hospital health system physician group, 3, 5, 10-year plan, workforce planning needs to be just as integral of a part as the inpatient, the hospital services as well. And then the other biggie is, let's get our recruitment teams back into the mix with developing these strategic plans. I'm talking to so many recruiters nowadays who don't know how the plans are developed, don't know how the roadmaps are created, don't know why they're recruiting 2 or 3 GI. I'm sure they know why they're recruiting GI. Everybody's recruiting GI. But that would immensely help with their satisfaction and also help them become better recruiters to see how all of it works together. And when you're pitching to physicians, you have a better sense of understanding for how they're going to get busy, how they're going to fit within the mix of what you're building within your community.
Yeah, 100% agree. I think the more information the recruiter or the sourcing team has as they're talking to candidates, because candidates are very knowledgeable. They're going to ask you about OR block time. They're going to ask you about procedure volumes or like, what happened? Did the practice implode? Why do you need 5 GI people? Well, maybe the practice did implode. So having them involved and at the table has been just a big piece of what I've done, especially as a leader, to make sure that they're there. So I'm glad that you support us and support us recruiter folks as we're out there, really in the trenches trying to fill these gaps.
Absolutely.
Yeah. So on behalf of PracticeLink, I want to thank Ron for appearing on Workforce Wisdom today. For our listeners, please feel free to reach out with any thoughts, insights, or questions you have about anything we covered. You can email plmedia@practicelink.com. If you're looking for a strategic recruitment partner, check out 3D Health's information in the PracticeLink Resource Center on our website at practicelink.com. My name is Christy Bray. Thank you for listening to Workforce Wisdom.